I'm Jill Lyon. I'm the Director of Rheumatology at the division at NYU School of Medicine. And I'm here today and really enjoying myself at the Lupus 2024 meeting. And I'm going to discuss just for a moment two presentations on pregnancy and clinical trials, which is something that really doesn't occur very often. So I'm going to start out with basically one that involves congenital heart block, and many of you know that that is a model of passively acquired autoimmunity, where a mother who may have Sjogren's syndrome or lupus, or actually be completely asymptomatic, generates antibodies to Rho52 and 60 in LA, which cross the human placenta via FcRn, and can result in congenital heart block in about 2% of patients, and rash in another few percent of patients. And the study I'm going to discuss is that called STOP-BLOCK, and this is a study supported by the NIH in the United States, and it covers about 22 centers where women are enrolled who have anti-Rho antibodies based on commercial testing. Women's antibodies are then tested in our lab at NYU, and if either antibody to Rho52 or Rho60 exceeds 1,000 EU, then these women move on to the second stage of the protocol. And just to mention that this 1,000 EU is the lowest level of which we have seen other mothers have children with heart block. Obviously that kind of data is expanding, but the point is to try to identify the higher risk mothers and then evaluate whether fetal home heart rate monitoring may actually pick up advanced disease before it becomes permanent, and is there going to be a window of treatment with IVIG and dexamethasone, in which case the block could be reversed. So this is just a report of 413 patients, more or less, that have completed 26 weeks of surveillance. And the data shows that actually about a third of the mothers who come in with commercial titer have actually antibodies that we think is actually below the level that would put them at risk for heart block. And in fact, in those 100 and something women, there were no cases of congenital heart block. In the mothers that had the higher risk antibodies, actually there were 10 cases out of approximately 261. And this, showed that these were the group that had the mothers had children with heart block. All of these 10 were picked up by the fetal heart rate monitoring, so the monitoring did work. There was not one case where the echocardiograms that were also done serially on these mothers picked up an abnormality that was not picked up by the FHRM. And so we also noted that the risk of block in the mothers with the high titer, who basically had never had a child with heart block, was about 3% or so. And this percent increased with increasing titer. But to say having the highest titers didn't necessarily mean that you were going to have a child with heart block. And in fact, the highest numbers, which we would suggest, of course, were women who had a previously affected child, and the very highest number was approximately 20% or so in women who had the highest quartile of anti-60 Rho antibody and a previous child with heart block. So I would also say that, importantly, 7 of the 10 cases were second-degree block. And this is really exciting because most studies show that when heart block is identified, it's already third degree. It's a little too soon for me to tell you how therapy worked in those patients, but we're hoping to see efficacy in those early treated patients. And importantly, the FHRM, because it's done 3 times a day, actually picked up block in some cases within 8 hours of a normal reading to an abnormal reading. So in summary, I think we have exciting data that we may be able to monitor or surveil women with these anti-Rho antibodies with a home device that they can actually listen to themselves. We're trying to work on a device that will actually tell the mother whether it's abnormal or not, because in this study we had a cardiologist listen to all the audio texts. We also, I think, can identify higher risk mothers and reassure those with low titer that they probably don't really have much of a risk for heart block. So the second study, which I don't know as well, was presented by Dr. Jane Salmon, and a very exciting study called IMPACT. And in this study, she was evaluating whether certolizumab, which is an anti-TNF blocker that is not thought to cross the placenta, actually will result in increased pregnancy favorable outcome. And in this study, she evaluated women who had an antiphospholipid antibody. Specifically, they had to have a lupus anticoagulant, and they had to have a previous pregnancy loss. And the long and the short in this really exciting study is that based or compared to historical controls where we see very poor outcomes in about 44% of patients, she reduced this rate, or rather not she, but the study showed efficacy such that only about 19% of patients actually had these very poor outcomes. The really exciting bottom line that she showed is that 93% of these women were able to take home live babies. And I think this is really quite an interesting and very exciting advance for women who previously had multiple pregnancy losses with these associated with antiphospholipid.